So first of all, I would like to take this opportunity and thank you for your kind invitation to this Congress. Today, I would like to show you a different approach to the sentinel lymph node concept in gastric cancer using immune flow cytometry analysis of the immune response in the sentinel lymph nodes as a predictor for non-sentinel lymph node metastasis. So, as you might know, gastric cancer is a disease notorious for its early lymph node spread. Thus, only an extensive lymphadenectomy can cure the disease by eradicating the metastatic lymph nodes. And the proportion of patients who are expected to carry lymph node metastasis can be estimated according to their T stage. If we look at the early stages, we can see that roughly 2 to 20% of patients are expected to have lymph node metastasis. Thus, if we perform an extensive lymphadenectomy in all these patients, more than 80% of patients will receive an unnecessary extensive resection where a smaller function-preserving operation could bring equal long-term results. But unfortunately, before the operation, there's no way to be 100% sure about the nodal stage, so we are still somehow gambling when we are performing an extensive lymphadenectomy for early gastric cancer patients. And from the introduction of the extensive lymphadenectomy in gastric cancer surgery, there really hasn't been much changes in the way we practice surgery until the early 90s, where some exciting changes happened in the field of breast cancer surgery and melanoma surgery with the sentinel lymph node concept, which helped to introduce organ-sparing operations for these types of tumors. Many researchers have tried to implicate the same principle into gastric cancer, but the results have been disappointing. The main reasons are because of the fundamental changes, differences between those types of tumors. In this slide, I summarized the main reason for unsuccessful implication of the sentinel lymph node concept. This is the complexity of lymphatic drainage, the micrometastasis, and the skip metastasis. So the gastric wall, the stomach wall, has a complex and multidirectional lymphatic flow, as opposed to skin, for instance, which has a more linear lymphatic flow. So we have to analyze a lot of lymph nodes to be sure about the extent of the disease. Then there's the problem of micrometastasis. Usually in the gastric cancer, the first metastases are in the form of micrometastases, which are harder to detect with routine histology used for frozen section in breast cancer and melanoma. Although immunohistochemistry and PCR have greatly improved the detection of the micrometastasis, but they are still too cumbersome to be put in clinical practice, so they can be only viewed as complementary methods. So another method that would be equally reliable but more faster is necessary to implement. So in our institution, we started to experiment with flow cytometry, which was originally used for hematological malignancies, and it's been shown to be a fast, reliable method which combines the high specificity of morphological methods and high sensitivity of molecular methods. But even if we were to find a sensitive method, we will still face the problem of skip metastasis occurring in 8 to 10% in gastric cancer patients. So we have to find another predictor for a non-sentinel lymph node metastasis, and the question is whether there is such a predictor. And well, I think there is. So the sentinel lymph nodes are not only the first organ where the initial metastasis develop, but they are also the first lymphatic organ that responds to tumor antigenic stimulation. Usually the tumor antigens are presented by the dendritic cells to the T lymphocytes and natural killer cells, which then develop into effector cells that kill off the tumor cells and prevent the lymphatic spread. But the tumor is somehow capable to induce local immune suppression. It prevents the effective presentation of the antigens by the dendritic cells, and the T cells in turn develop into a special subtype of T cells, the regulatory T cells, which suppress the immune response and permit metastasis formation. And these changes can be histologically seen as reduced aggregate area in the paracortex, reduced area of the node occupied by the dendritic cells, reduced number, maturity of the dendritic cells, reduced number of the high endothelial venules, reduced translocation of the T cells, and finally, reduced number and activation markers of T cells. Now, this is something we can work with because flow cytometry is the ideal method for detection the number and the subspecies of T cells. And we know from previous studies that regulatory T cells expressing high levels of FOXP3 antigen are capable of suppressing the immune response and permit metastasis formation. They are most probably induced by the tumor itself. So if we could find and detect this subset of T cells expressing FOXP3 antigen, there might just be an indirect sign for lymphatic spread. And we can detect these cells by their surface antigenic markers. They are CD45 negative. They express high levels of CD25 antigen, which is an interleukin-2 receptor, and low levels of CD127 antigen, which is an interleukin-7 receptor. So our question was not only if we could detect the tumor cells with flow cytometry directly, but more so if we could use flow cytometry and analyze the immunological response in the sentinel lymph nodes as an indirect predictor for non-sentinel lymph node metastasis. So we included 21 patients. We performed intraoperative dye navigation. We extracted only the first draining sentinel lymph nodes, so only the one lymph node was analyzed. Before the operation, we additionally used the Mariama computer program to estimate which was the most likely first metastatic site. This is a case of a patient with a submucosal tumor lying in the antrum, and you can see in the 6th lymph node station there's the highest possibility of first lymph node metastasis. So during the operation, we injected the dye, followed it to the first draining lymph node. This is the pylorus, this is the infrapyloric region, and the first discolored lymph node, which was then extracted and sent for analysis. Each lymph node was then halved. One half was analyzed with flow cytometry, the other half with frozen section, while the remaining tumor specimen was analyzed with histology. Then we compared the immunological response in the sentinel lymph nodes between patients who were, after the operation, node positive and node negative. First of all, we were interested in the correlation between clinical pathological factors and non-sentinel lymph node metastasis, and the univariate analysis showed only 3 significant predictors. First of all, there was the frozen section, which could correctly stage intraoperatively 71% of patients with a sensitivity of 100% and specificity of 62%, which means that there was a high false negative predictive value. Then the second was the lymphangial evasion, which was present only in 63% of patients who were node positive and absent in 90% of patients who were node negative. Tumor size, with bigger tumors more likely to have lymph node metastasis. And the ulcerative appearance, which was associated with higher likelihood of lymph node metastasis, but this only reached borderline significance. So excluding the frozen section, we can see that all the formal prognostic factors are only available after the complete histological workup, so they're useless for intraoperative lymphadenectomy tailoring. Now, how about the flow cytometry? The direct detection of tumor cells was performed with the detection of the surface epithelial markers, CACAM5 and EpCAM markers, and we set the threshold level at 300 events on the background of 600,000 cells, which produces an acceptable level of reliability. This is a case of a positive sample of metastatic lymph node. In the first step, we gated off cell debris and dead cells. Then from the remaining cells, CD45 or mononuclear cells were excluded. And then the final steps, we looked for cells expressing both markers, and if we had events in this region, that meant that tumor cells must have been present in the sample. In this way, we could correctly stage intraoperatively 71% of patients with a sensitivity of 100% and specificity of 62%, which is equal to frozen section. In borderline cases, where the events were at the threshold level, we additionally used imaging flow cytometry to directly visualize the tumor cells and increase the specificity. This is a case where 2 tumor cells conglomerate were found, and at a high magnification, you can clearly see that tumor cells have larger hyperchromatic nuclei with nucleoli inside. And if you pay attention to this cell over here, you can clearly see that there's a damaged cytoplasm. This is because of the way we prepared the samples for the flow cytometry. All nodes were subjected to soft tissue mean sink, which inevitably destroys some of the tumor cells. This is the reason why we had somewhat lower specificities for this analysis. And now the immunological analysis. We're interested in the immunological response, or especially in the number of regulatory T cells. So we restricted the acquisition gates to CD4 positive, CD25 positive, CD127 negative, and CD45 negative cells. This is one positive case. First of all, we gated off CD127 positive cells. From the remaining cells, we looked for CD45 negative cells who express high levels of CD25. These were cells expressing FOXP3 antigen or suppressive regulatory T cells. And then we compared the distribution of the regulatory T cells between the patients who were node negative and node positive, and we saw that the patients who were node positive had significantly higher values of regulatory T cells in the sentinel lymph nodes, especially activated regulatory T cells, and this was confirmed in the multivariate analysis, which showed that the relative proportion of the regulatory T cells expressing FOXP3 is the only significant predictor for non-sentinel lymph node metastasis. Then we tested the predictive value and compared it. The preoperative diagnostics could only correctly stage the nodal stage in 66% of cases with low sensitivities and specificities. Like I said before, the frozen section and the direct tumor cell detection had a diagnostical accuracy of 71.4% with a sensitivity of 100% and specificity of 62%. Then the measurement of the regulatory T cells had a diagnostic accuracy of 80.9% with a sensitivity of 72% and specificity of 90%, and the direct detection of activated regulatory T cells could correctly stage 85% of patients with a sensitivity of 81% and specificity of 90%. This could be further increased by the combined detection of tumor cells and regulatory T cells, which could correctly predict 90% of patients with a sensitivity of 90% and specificity of 90%. So looking at other studies in gastric cancer surgery in which the sentinel lymph nodes were analyzed with a frozen section, they were all battled with the same problems. This is the high false negative predictive value. Unlike the flow cytometry, the combined detection of tumor cells and FOXP3 expressing regulatory T cells could accurately detect non-sentinel lymph node metastasis. And only to remind you, the flow cytometry takes only 2 hours from start to finish, while the PCR takes 6 to 8 hours. So taken together, the flow cytometry is not only fast, reliable, it is highly sensitive, specific. It obviates the need to evaluate more than one sentinel lymph nodes because we are not limited by the direct detection of tumor cells, but we can rather indirectly predict non-sentinel lymph node metastasis according to the immunological response, and this solves the problem of skip metastasis. So immunoflow cytometry can be viewed some kind of a safety net. And I think in the future we will see a move away from chance navigation to more lymph node navigation, which is more certain. So the immune flow cytometry, I think, will bring in the future an uprise of the sentinel lymph node concept in the gastric cancer surgery also. Thank you.
Thank you very much for your presentation. Very interesting. I don't know if any of you have a question regarding this technology. Just maybe one question. Flow cytometry this is really on the research base, I imagine.
Yes,
yeah.
This is, as of yet, a research base, but we'll take it to a clinical phase. So we'll include more patients, and hopefully in the future we'll decide about the extent of lymphadenectomy, about the flow cytometry.
Okay. And so this on a practical clinical basis, so this means that you have to return anyhow to the patient to get the lymph nodes if they come back positive?
No, the clinical value of these studies or the procedure is planned to be like this. During the operation, we extract the lymph nodes.
Yeah.
And then this is especially for the laparoscopic subtotal gastrectomy. It's applicable for laparoscopic surgery. So during the initial phases where the stomach is mobilized and the first tiers of the lymph nodes are extracted, then usually the results come in. This takes only 2 hours, and then we can decide whether to proceed to an extensive lymphadenectomy or even convert to open surgery or perform only let's say a smaller resection. But there's another possibility for this methodology. Japanese authors, I think the presenter before me also showed a similar approach for colonic tumors. So for mucosal tumors, they used endoscopic submucosal dissection, and if the tumor invaded the margins or had was unfavorable and had a higher chance of lymph node metastasis, they proceed to salvage operation. But during the operation, they performed sentinel lymph node navigation, and if the sentinel lymph nodes were negative, They performed only sleeve resection or virtual resection, which is even a smaller resection, and resected only the lymph node basin, which means only one lymph node station instead of the whole tumor and every lymph node station. And if it was positive, they proceeded to an extensive operation. The problem was, like I said, the high negative false negative predictive value. And our intent is to lower this high, negative predictive value.
Using flow cytometry.
Yes.
Okay. Yeah, very interesting. Thank you very much.
Thank you.
Yeah, sorry. One question.
Sorry, yeah.
Hello. Very interesting and very, very nice presentation. I think this technique and all the reliability that has is very powerful for screening and helping in the clinical practice. So from the more basic side of the gastrointestinal diseases, this population that you characterize, do they express other, I don't know if you are planning to do or you already check some regulatory markers like anti-inflammatory cytokines like GGF-beta that can be important in promoting this microenvironment of the tumor, or CTL4 that has been shown in the, I don't know if in gastric cancer.
Yes, there have been some studies, of course, that show that pro-inflammatory cytokines were very crucial for the tumor spread in the lymph nodes. But in our study, we only restricted to the regulatory T cell detection because it's the most convenient form of detection for the flow cytometry. So, but basically, like I showed you in one slide, there are many changes happening in the sentinel lymph nodes from the level of the dendritic cells to this cytogenic expression. Then the surface markers are changed, and there are many targets where also this knowledge can be used as target therapy for to modulate the immunological response in the cancer patients.
I'm sorry, no, I was referring to CTL4, that is a surface marker of T regulatory cells that can be also used for therapy. For example, there are some interventions. Or
yes, we are aware of. I'm aware of that, but we didn't use antigens to detect this marker. So we're just interested in the regulatory T cells, so expressing FOXP3, and so we use only these markers, like I showed you before. But of course, the flow cytometry can use many marker detection simultaneously, and you could theoretically also use flow cytometry to detect these markers, marker which would be a great therapeutic target.
Thank you.
Well, thank you very much.